pusat permainan American di Osaka. Pusat permainan anak-anak universal bola bumi. Ini adalah bola bumi, tampak anak-anak di Jepang pada hari libur sangat ramai. Ini fantasi Ancol Dufan.
particularly combination therapy in lamivudine resistance, and actifovir and lamivudine combination in the reduction of actifovir resistance. The question is the novel combination necessary, and what combination and how to combine? We still need some stopping rules because lifelong treatment, someone doubts that is that feasible and affordable, particularly in the Asia Pacific region. So, but we have a reliable stopping rules, as you just heard from the previous discussion. This need to be discussed. According to the new guidelines of U.S. experts panel, they suggest that to
so I think that for patients who are non-cirrhotics, who have no contraindications to use of interferon, and who are not so sure they're willing to commit to 5 or 10 years of treatment, interferon is an option.
Well, when I was young, and then the patient was young also, there are so many ENGen positive patients in Japan, but now there's no many patients ENGen positive. So it was a great experience to have fluctuating enzymes in the late 20s or early 20s, and then to treat the metabolism and cell conversion, and look, you have a normalized everything. It was a nice experience. That's the way you do it. Mario, how are you? I mean,
I'm doing very well.
How's that? Your patient doing?
I am very much in favor of interferon in younger people, and I agree with Anna. But I also have trouble convincing patients. I know Bob Perillo says if you're convinced, you'll convince your patients. But we have a large number of this antigen replies surface antibody. And I know those studies are small in number, but I think if you change the immune modulatory response, you may in fact, even after stopping therapy, get a longer term benefit. And the problem is none of the big studies have looked at that at 5 or 10 years.
It is said so for a long time, but nobody really showed significant.
Kornman showed it.
Okay. But I still remember Anna said, those days, those days means a lot of days, but Anna said, look, in Europe and the United States, there are so many data showing cell conversion, loss of HBsAg, but maybe they are different. We Asian maternal transmission, how come you can get cell conversion so easy? And in fact, it is really true. Anna, how do you think? Why don't you have a high hope?
That's why I invited Anna, not because she's from Asia.
But anyhow, CL. You are involved in so many drugs and then so many different studies. How can you maintain yourself?
What do you mean? Anyway, with nucleoside loss, even with lamivudine, actually, as you know from our study, if the DNA are negative by PCR by week 24, the resistance is 29 months with only 8%. So I think there are something by which we can actually guide ourselves in treatment with nucleoside loss. We treat them early, we check.
Suasana selesai kongres tempat Dr. Salomber terus saya
is the HBV producing plasmid of typical promoter mutations. We collect H-metin on day 3. We found that the dentate tended to have the highest HBV DNA level in the median, and this is the typical promoter mutation. Discussion: genotype C is more prevalent than genotype B in HCC patients in Taiwan. HBV genotype C is not significantly associated with long-term survival in HCC patients underwent tumor resection. HBV with typical promoter mutational codon mutations is associated with poor survival. The presence of these mutations was associated with high inflammatory activity and fibrosis, which may adversely contribute to
this presentation. But I'm very wondering, the Cossack mutation was already reported strongly associated with genotype A, African type. This is the first report, except the genotype B and C, Cossack mutation. Is there any associated with why? Is there any explanation to this one? If the Cossack mutation has occurred, the viral load will decrease dramatically. It's reported. Is there any associated to this Cossack mutation to develop the hepatocellular carcinoma?
In our study, we didn't compare the incident carcinoma in population with infected by HBV with codon mutation, but we emphasize that patients with infected by HBV with codon mutation or typical mutation, they have a more progressive disease course and have a poor survival. And our findings are supported by
to define thresholds for normal or elevated levels of ALT. Similarly, viral loads have also been used as a marker for defining candidates for therapy. There is controversy in the light of emerging data surrounding the viral lymph flow threshold for initiating treatment. The question remains as to whether viral load of 10 to the 5 copies per ml is an appropriate threshold for distinguishing between active and inactive disease.
1,000 units is a consideration here, and for the decision to treat. For the Keith guidelines, what recently published, the threshold here or the stratification point is DNA. HBV DNA less than 20,000, HBV DNA greater than 20,000 for E positive disease, and they've adopted the European position of less than 2,000 or greater than 2,000 for the E negative. These authors make the point that the use of ALT levels to define chronic hepatitis B patients as candidates for treatment derives from historic experience helps to define the cohort that's most likely to respond rather than as a disease state appropriately in need of appropriate antiviral therapy. So really the question that could be asked is when should we treat patients with chronic hepatitis B? And this slide attempts to distill the US and I think that the conclusion can be made from this slide that when the ALT is elevated, the level of HBV DNA defines who is to be treated and who is to be biopsied. So I'd like to leave you with this call to action in chronic hepatitis B. Are we doing